and really get on that, that mental masturbation about. Welcome to another episode of Why I Didn't, the mostly useless series where I tell you why I did not pursue a particular specialty. And today we're talking internal medicine. If you want a more useful and objective overview of internal medicine, then check out So You Want to Be an Internal Medicine Doctor over on the Med School Insiders channel, link in the description. Now consider this the opposite, my subjective, biased, limited personal experience with that specialty. And if you're a pre-med trying to get into medical school, then check out the Med School Insiders Pre-Med Roadmap to Medical School Acceptance course. It's now on sale for a limited time, coupon and link down in the description. And channel members get a larger discount. With that being said, let's dive into internal medicine. So what I liked, first off, is the variety. Internal medicine is essentially the heart of medicine. I know, you would think it's cardiology, but it's not. Internal medicine sees the widest variety of things within the field of medicine. Most of what you actually learn in medical school is still relevant in internal medicine, so you're not gonna feel like all those countless hours spent doing real-world questions is going to waste. In contrast, a lot of other, especially surgical subspecialties, tend to narrowly focus you and then you forget most of the things that you actually learned in medical school. Like the stereotype of orthopods who don't remember anything about hemoglobin A1Cs or diabetes or different antibiotics.
Okay. Continue 3 of the most important ones and switch all the others to ANSEF. Just stop, okay? We'll admit the patient. Yes.
Now, obviously it's a varied specialty, but the bread and butter that you're going to be seeing within internal medicine is going to depend on how you practice. So after residency, are you going to pursue a fellowship, do something like cardiology, gastroenterology, endocrinology, et cetera, and then also are you going to be in the inpatient or mostly outpatient setting? Broadly speaking, in internal medicine, the bread and butter is spread across multiple different organ systems. And there's also some level of variety with the procedures. Now, obviously these procedures aren't going to be as varied or complex or stimulating as surgery, but you're at least working with your hands. You'll be doing things like central lines, intubations, paracentesis, etc. And some hospitals even have an internal medicine procedural service to help with procedures all across the hospital. Next up is intellectual stimulation. As an internist, as a primary care doctor, you're on the front lines. And when a patient comes to you with their concerns, you're now the quarterback. And do you handle it yourself or do you pass it over and refer to a specialist? Occasionally, for the more complex cases, you're gonna feel like a medical detective trying to solve the medical mystery. And of course, there's some degree of excitement to that, some critical thinking involved. And for a lot of us, that intellectual stimulation is part of the excitement of medicine, part of the reason why we pursued it. There's definitely a lot more critical thinking within internal medicine compared to a lot of other specialties. Next up would be relationships. Now, especially in the outpatient setting, IM allows you to see patients longitudinally over several years. And of course, you're gonna build relationships with patients. And building that relationship with your patients can be not only incredibly rewarding, but it adds meaning and purpose to your work. And overall, it leads to greater levels of happiness and satisfaction with your job as being a doctor. And that's something that is often missed from a lot of other specialties, like surgical subspecialties, anesthesia, radiology, and so on. Next up is flexibility, because after you finish internal medicine residency, there are so many things available to you. If during residency, you found a subspecialty that you enjoyed, you can do a 2 or 3 year fellowship after completing your IM residency and then become a specialist in that field. Some of these specialties include cardiology, gastroenterology, infectious disease, nephrology, and so on. And you can find all of these and more on the So You Want to Be playlist over on the Med School Insiders channel. You can also decide to skip fellowship and start your life as an attending physician after just 3 years of residency, which is nice and short. This path also gives you a few different options. If you enjoy the outpatient setting more, then you can become a primary care doctor, open your own primary care clinic, and become the patient's center of care. Patients are gonna come to you for vaccinations, wellness checkups, management of stable and chronic conditions, and new concerns for which you may refer them to a specialist if they do need specialized care. Alternatively, if you like the inpatient setting more, you can become a hospitalist. Whenever patients are admitted to the hospital for a generalized medical problem, you as the hospitalist are the one in charge of them. You're the one responsible for their care, treating them as you see fit, and then of course, consulting other services as necessary. But the really cool thing about being a hospitalist is the work schedule, which is often 7 days on, 7 days off. That means you work 1 full week on and then 1 full week off. So working half the year, you're essentially making $250,000. Not a bad gig. That being said, those 7 days on are pretty challenging, and you're more or less working nonstop from the moment you clock in to the moment you clock out. If you're a bit of a masochist, you can also be a nocturnist, which is the same thing as a hospitalist, but you're working the night shift. And nocturnists make on average about 15% more than daytime hospitalists because they're working a less desirable shift. And of course, it's only fit for some people. Most people are not really happy doing this. Maybe you're the type that really likes rounding. You wanna spend 4, 5, 6+ hours a day rounding in the hospital before you actually get to your real work. And if that's you, then you should go into academia where you can teach the medical students and residents and really get on that, that mental masturbation about the nuances of optimal patient care and evidence-based medicine, and should we use this antibiotic versus that antibiotic? Of course, there's also rural medicine if you want to help patients in underserved areas, and then also refer out to less specialists, because in rural areas there are fewer specialists, so the general practitioners tend to have more responsibility. They're handling more things. All right, now what I didn't like. Speaking of rounding, I did not like rounding. Surprise, surprise. While internal medicine is sometimes very intellectually stimulating and you can think a lot about this puzzle in front of you, sometimes that puzzle takes way too long to solve. IM doctors are notorious for spending so many hours on their morning patient rounds, especially in academia, of course, because you're teaching the med students and the residents. Don't get me wrong, it's of course very important to discuss all the various treatment options for each specific patient, and especially teach the med students and residents who will be doing this in the future. But when you've been rounding since 7 a.m. and the attending decides at that moment that, hey, let me start a new 1-hour conversation about sodium, that can be brutal.
Please, this patient has everything you guys like. Neck veins, a surgical incision you don't have to look at.
Sodium?
I do kind of like sodium. No, that's not gonna work this time.
Sometimes rounds were cool, but oftentimes they're just tedious, especially when it was just back and forth about a couple of specific papers having really minor differences in treatment. If you're an impatient person and you like to go, exhibit A, then rounding is not a good time. This is one of the reasons why I generally prefer surgical subspecialties, because rounds are short and sweet, and then you get to go do the fun stuff. Surgery. In surgery, your goals for admitting and following up with a patient are usually more straightforward. You're bringing in the patient, you're giving a specific type of management, you may be doing some surgery if it's indicated, and then you're following up with them until they're discharged. Some surgical specialties don't even admit their own patients. They're admitted to medicine, and then the surgical team acts as a consulting service. This brings me to my next point, getting dumped on. A lot of the time, other specialists will try their hardest to get you to admit their patients. Now, admitting a patient when you're the one responsible for them as the medical team, that means a lot more administrative work, a lot more responsibility, a lot more supervision. Subspecialty teams would much rather have the medicine team admit the patient, and then the subspecialty team can act as a consulting service. They can follow the patient as closely as they need. Maybe they see the patient once a day, or maybe even less frequently, and then provide recommendations to the main medicine service. And when you're a consultant, you also don't have to deal with things like discharge and other administrative responsibilities. And this happens a lot as internists, where you just get dumped on and then you're kind of stuck. Now, as the IM doc, you're stuck admitting a patient who may just need more specialized care. You're taking a bed away from someone else who may need it for a more general internal medicine problem, and instead you're just babysitting someone else. And now, not only are you dealing with administrative tasks and of course the issues with discharge at the end of their stay, but you now need to juggle all the various consults and recommendations that you're getting coming in. Sometimes you'll actually have 2 different consulting services giving you 2 opposite recommendations, and then you're just stuck in the middle.
We had a minor disagreement. The cardiologist is covered in saline. You held him down and drew a QRS complex on his forehead. This is more than just a minor disagreement.
Next up is the bread and butter. Zebras are always fun in any specialty, but as I always harp on this channel, you have to consider the bread and butter when you're looking at which specialty to choose. The bread and butter is what you're gonna be seeing day in and day out on most days. Now, of course, this is gonna vary a lot based on if you do subspecialize with fellowship, but also even in general internal medicine, are you in the outpatient or the inpatient setting? With clinic, with outpatient, there's generally less complexity and less urgency. It's more straightforward, things like wellness checks, infections, diabetes, blood pressure, and so on. If you do get more complex and specialized presentations, then you refer them out. Now, of course, clinic is very important, but for me personally, I found it a little bit more tedious, a little bit more monotonous, and that bread and butter wasn't as exciting to me. Oftentimes, it's dealing with chronic conditions, and that requires patience. You're dealing with long-standing hypertension, you're dealing with diabetes management, you're dealing with an exacerbation of COPD. You feel like it takes a long time for patients to get better, and you don't really feel like you're curing the patients often. It's more that you're just controlling their disease. A lot of this management requires a great deal of patience from the provider. And when providers can do so, it's actually really impressive, really admirable, especially when you spend so much time with motivational interviewing techniques. You really feel like you made some progress with the patient, and then they come back 6 months later and their lifestyle hasn't changed at all, and their diabetes is now even worse. It can be really frustrating when the missing piece is the patient implementing some lifestyle changes, and there's only so much that you can do. A lot of primary care medicine is lifestyle stuff. It's things like stop smoking, drink less alcohol, exercise more, eat better, take your medications. And of course, not all patients are able to follow those recommendations. And this leads to a lot of stagnation with patients' medical conditions, and sometimes even worsening. And there's only so many times you can tell a COPD patient that, hey, you have to stop smoking. And last, the administrative obstacles. IM deals with so much administrative and charting burden. Part of this is actually due to, again, serving as the dumping ground for other specialties, but there's more charting even beyond that. More time is spent placing orders, writing follow-up notes, and coordinating with all the different teams. Another difficult part about being the primary team is dealing with the social work aspect of patient care. Some doctors go as far as to say that they're glorified social workers, which is of course an exaggeration, but there's some truth to it. In the academic setting, this is something that the residents deal with more so than the attendings. A big part of internal medicine is dispo, short for disposition, which means where does the patient go after they are discharged from the hospital? Are they safe to do so? Many times the patient's condition has actually improved medically such that they are safe to be discharged from the hospital, but because of dispo issues, maybe the rehab center, the rehab facility, or the nursing home, they're not ready for that patient. They don't have a bed for them or some issues with insurance. The patient is stuck sitting on your service. And in the meantime, you have to keep rounding on them, keeping tabs on them. And of course, the hospital is an incredibly dirty place. And the longer someone is in the hospital, the more time you have for issues like infections or other things to arise. All right, so finally, what if you are considering internal medicine? Internal medicine is considered the default specialty. It has the widest net of them all, and some people are really drawn to it, whereas others find themselves just falling into it because it's the default and they didn't really know what else they would do. Nothing else really drew them that strongly. If you are considering IM, remember that it is such a broad specialty, not only with practice setting of hospitalist, primary care clinic, etc., but even with the option of doing fellowship afterwards. If I were to sum it up, I would say that internal medicine is really good for those who are drawn to the cerebral aspect, the intellectually stimulating and critical thinking aspect of medicine. They are patient, definitely more patient than surgeons, and they don't mind having a greater administrative burden than some other specialties. If you're a pre-med, then remember to check out the Pre-Med Roadmap to Med School Acceptance course, which is currently on sale, linked below this video. If you want to learn more about internal medicine, then check out So You Want to Be an IM Doc over on the Med School Insiders channel, or another video from Why I Didn't. Much love, my friends, and I'll see you guys in that next one.